Hello, everybody. This is Susan Clinton, and welcome to podcast number 27. This is actually our year anniversary between Erica and I in doing podcasts, and we're very grateful that you all have found us. And we're also excited about all the great comments we're getting. We hope that this podcast continues to help you. As you get ready to listen to it, it is deep in the summer into August, and I think everybody's anticipating kids returning to school, routines kind of returning towards the fall agenda. The daylight hours are getting shorter here, and we just are very grateful that we've been able to do this podcast for a year, and we're looking forward to a few years to come. This particular episode is about a ballet dancer. I've talked about dancers before on this podcast. This is a young woman who is coming from a typical ankle injury and has had a myriad of treatments, none of which have been successful with her. What makes this podcast unique is taking a look away from the foot and ankle and trying to get her to tell me what she thinks is wrong, and looking at the entire movement system to see where we can find the right interventions that may have been the cause of her ankle and foot problems from before, help her to be able to gain some insight and some movement patterns that will help improve her balance, as well as get her moving better over the right side of her body. Let us know what you think. Thank you very much. Hello, everyone. Welcome to Tough to Treat. I'm Susan Clinton and my co-host Erica Mello. Hi, Erica.
Hey, Susan. How are you doing?
I'm doing well today. How are you?
I'm good. For the middle of our hot summer here, huh?
Yes. And it is quite hot on the eastern seaboard. I just got back from a 12-day vacation at the Newfoundland and Labrador coast, where it was a bit chillier, I might say. So it was very interesting coming home to the 80-degree heat. And I know the people in the South are laughing at me right now. And I am from New Orleans, and I know that it is unbearable down there. So it's all relative, however.
I know. You know, it's funny. I don't mind the heat so much. It's the humidity that just does me in. It really does. But it sounds like you had a fabulous time. Your pictures
it was. I recommend it to everybody.
I wish we could all treat patients and, nice scenery all the time.
Wouldn't that be fun?
Yes.
Okay. So are you ready to get started?
I am. Let's
go.
go.
Well, we're going to revisit the dance world again today.
Great.
I want to talk about a young ballet dancer that I had that came in with right foot pain, and kind of an interesting way that she ended up being in physical therapy and taking a look to see why she was having so much foot pain. So anyway, to get right started, a young ballet dancer with right foot pain, mainly she would kind of point to the medial arch, and just right underneath the medial malleolus is where her pain was. She said it started when she was working on pointe. And over time, it progressed to where when she was doing releves on flat, she was having the pain, and now she's also having it with landing. So this all occurred before I saw her. This had started, probably been going on for about 8 weeks. She finally, when it started, hurting when she was landing, is when she finally ended up, her parents took her to a physician. And she was told she had tendonitis and that they wanted her to rest her foot for 2 weeks. And if that didn't help, they were going to inject her.
Oh, boy.
So they put her in a boot.
Oh, boy. So
which is kind of like, here we go.
Yep.
So post-boot, now she has stiffness.
Of course. So she was in a boot.
She was in a boot for 2 weeks.
For 2 weeks, and then she had it for 8 weeks prior to seeing you.
Yeah.
This is 10 weeks now. Okay.
Yeah, right. So we're kind of moving into that first month,
Yeah.
I mean, that the 3-month, mark here.
Got it.
Which was, so coming out of the boot, she would complain of a lot of stiffness, and the pain was still there.
Oh, of course.
Her parents did not want her to have an injection, so they talked to the studio, and my friend, the PT that his wife runs the studio, it said, you need to get her to physical therapy. Like, go see Susan. Just, in his words, he was like, you should have done this earlier. But doesn't matter. There she is,
Yeah, exactly.
and quite frightened, because she doesn't understand where pain is coming from, and she doesn't understand why her foot hurts, and she's always done everything the way everybody's told her to do it. And she did the boot, and she was very good, and she never came out of it except when she was supposed to. And why is this all happening to me? She was quite upset. You could tell she was holding it back as much as possible.
Yeah.
And, this is the middle of the spring for her at this time. And many of these young dancer ballet companies and studios and things, they're ramping up, getting ready for their ginormous spring gala or their spring performance or their spring recital. And she was really agitated and upset. And, so there was a lot of listening. Her mom kind of hung out in the room, which was fine. But after a certain point, she just said, I'm going to make a couple of phone calls. I'll be back, which was wonderful. So she had a chance to kind of just like unload. She wasn't like angry at any particular person. She was angry at the situation.
Yeah, for sure. How old was she, Susan?
Around 15.
Oh, 15. Okay.
Yeah. So, at that great age where they're just learning to really, come into their own and express themselves a little bit better, and they're not quite so squelched down yet. So it was good. I encouraged her to tell me everything and tell me everything that had happened, and, what other kinds of problems has she ever had with dancing, because of course this is the only thing that's ever happened to me, blah, blah, blah. Well, come to find out, no, I've had, of course, I've sprained an ankle. I can't remember which one. Maybe it was my right one, running, a couple of years ago. Just different kid things, so it's, I just wanted to remind her that she's had things that she recovered from before. That this wasn't, although this has lasted longer, it's still, the potential for recovery is there, because I think she was feeling pretty hopeless. So we did that, and I just wanted to kind of, how I like to do this. I wanted to check in and find out what she thought about it. I wanted to know what she felt was wrong. I said, you've told me what the doctors have said. You told me what everyone has said. What do you think is wrong? And it was really interesting. She said, I can't balance over my right foot. And I said, was that before the pain or after the pain? She goes, it's always been harder to balance on my right foot than my left foot. And I said, so what does that mean to you? And she goes, well, I'm just wondering if that's why this started. And I said, okay, I think that's fair, because you know yourself better than anyone else. And, I'm not going to just poke my fingers at your foot. I want to look at you move, because we need to kind of help you solve this problem. And then, she had this look on her face, and I said, I'm not going to tell you not to go to ballet. First of all, you're going to go, and for the stuff that you can't do, you're going to watch.
Right.
I talked to her a little bit about mirror neurons, and
yes, exactly. That's a great idea.
And I talked to her about activation in her brain, even though she wasn't doing the activity, that watching it can bring that, So I said, there's important stuff going on. It's not just because they want you to be there and torture you. It's there's reasons for you to watch. I said, however, we're going to get back to you're going to start tomorrow back in class at bar, and I'll tell you what you're going to work on. So she was delighted about that. And it was like, there are things that you can't do yet, but we're going to work you into all of them, and then we're going to work you into center floor.
Yep.
So I had to get the buy-in there with her, because otherwise she was going to be passive and sullen, sitting there with her foot, in my hand, like, what are you going to do different than anybody else has done?
Right.
So I looking at her, kind of doing the PT exam here, and jump in whenever you want to, Erica. But, we always talk about posture, but I just wanted to see what's dominant with her. So I had her stand up, and I had her, I just stand, like you're talking to your friends at school, stand for me. There were some things that was expected, a little bit of weight shift off to the left, because we've been wearing a boot for a while.
For sure.
And, now the stiffness in the foot that she was complaining of. But one of the biggest things I noticed was, and it's not atypical of young dancers to see this posture, young gymnasts, but that the thorax really, lifted, anteriorly and superiorly in the air. I think Julie Weeb calls it bell rung up, but whatever. They, kind of noticed that with her. And I also noticed with her a really pretty, significant forward head. So
interesting.
It was interesting, because usually with kids, their head is going this way and that way and whatever. I mean, she really kind of like would in order to move her head, she would jut her chin forward, because I was talking to her and asking her questions and moving around so that she wouldn't feel like she was on stage with me peeking at her
Right.
posture.
Right.
We were just talking about certain things. We did some weight shift and some, picking one foot up and the other foot up. I wanted to see if she indeed could shift weight onto that right foot and lift it up, and what would happen.
Yeah, it reminds me of remember I forgot what podcast number this was. Remember the dancer that I had in the Broadway show? Same thing, right foot pain, medial, posterior tib area, and she was way off to the left, but she had a significant shift in her thorax. What did this girl look like? She was more superiorly, like with the head, rather than shifted.
Yeah, she was. Yeah, so she wasn't. I was, kind of wondering maybe she was shifted to the right with her thorax. I was just kind of looking, to compensate for the left shift, over. But she basically was kind of just all that. The right leg was out to the side a little bit and externally rotated a little bit. Like not weight bearing, but everything else was pretty lined up. It's just that she had this big, kind of shift upward and this kind of forward head thing that, kind of looked like to me, was kind of like, it looks like it's kind of driving the system here a little bit.
Interesting.
So, when you think about that a little bit, I also want to think about structure. So I had a chance to see her mom as I kind of saw her mom a little bit later, some of the same tendencies a little bit, because you are what you are, who your parents are, structure is structure. We're not going to change it so much, but, we want to balance around it for sure.
When you weight shifted her, was she like right to left? Did she just really end up like what I do sometimes is I'll just weight shift. I'll try to center them. I generally stand behind the person and I marry my feet to their feet, and just to get a sense of where their body is, even though my body may be a little off, and I'll just weight shift them side to side, and then I'll center them to what I think is my center, and it's different for everybody. And then I'll let go and I'll see where they land, and then I'll do the AP like we had talked about in other podcasts. Right. And I just see where their path of least resistance is, or I think what does Shirley Sarman call it? DSI or something like that, direction susceptibility of something or other, but it's that's where they go naturally. And did she have anything like that in terms of sway?
Yeah, so the interesting thing is when she shifted from right to left, when she would shift to the left, she would really shift way over, to the lateral border of her left foot. When she shifted right, she would shift pretty much to center of the right foot.
Oh, interesting. So she couldn't really weight shift all the way over on the right side at all.
I could push her, but naturally, like you said, I wanted to see what her tendency was.
Right.
And I knew she was walking, so she had to be shifting her weight to the right. I just wanted to see how far she was willing to go before I kind of encouraged her. So I just told her, I said, make it feel the same on the right as the left.
Right.
With your weight shift. So she did. I wanted to see what she would do willingly with cues before, she's had enough people like tell her what to do. I wanted her to start to figure it out. So I had her just willingly do it. And she played around with it for a while. I said, shift forward and back a little bit, shift side to side, shift in a circle a little bit. We just kind of, we start looking at the exam and I start treating right away. And so she was able to kind of, go, a little further and do a little bit. And what was funny is she would shift to the left, she would drop her trunk she would shift to the right. She would actually side bend or drop her trunk. I wouldn't call it side bending so much because the hip wasn't lifting, but she would just kind of like drop her trunk to the left, into that left frontal plane. Just
so she shifts
over.
So she went over onto the right leg. Right. She would shift her thorax or trunk to the left.
Yeah.
Okay.
Well, she would drop it to the left. So actually her trunk would shift to the right with it, but she would drop to the left. You see what I'm saying?
Yes.
So we end up with that kind of C thing.
Got
it. And what was interesting was just watching up the chain is that she was staying very, 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 very stiff, from the TL junction up. Kind of like, and so put my hands on her thorax, just, her lower ribs, wanting to get a feel for what was happening around that TL area and to see if that would influence anything at all. And I just had her go back. I said, I'm just going to put my hands here, just do your thing again. Yeah. And all I did was just try to see what was happening. And it was all really, the movement pattern was all happening there at the TL region.
Did she have any like I just check for rigidity, so I'll put my hands like you did on the thorax, and did she have like any wiggle in her thorax at all? Or
No,
soft
not
flat?
above, not above. But most of all the movement that she was, achieving through that area was happening at TL.
Yeah.
So if I went up on her ribs higher, that was just staying still. I mean, you could feel, we would turn sideways, but it was turning at the TL. It wasn't turning at mid-thorax,
It was hinging,
or anything like that. So she was really hinging there.
Got it.
Which not totally unexpected, not a terrible thing, but kind of important. So I had her lay down. I wanted to do a quick hip exam because I always, with young females, I always want to see what their tendency is in their hip joints, particularly thinking about retroversion versus anteversion, and an anteverted hip being forced into a retroverted position for ballet. And I wanted to also see if she could move her hip without moving her back. What was that disassociation looking like, and those kinds of things. So I ran through a couple of things, just getting her to move, trying to get her to see if she could actually bring her thigh up into full flexion into the sagittal plane without deviating out to the side or towards N. We looked at rotational movements in prone and, did some different things. There was a slight difference right to left. She didn't have as much retroversion on the right as on the left. She had much more of a natural turnout retroverted kind of hip on that left side. The right side, I would say, was probably about 30% less, but she wasn't like anteverted or anything like that. So that was kind of interesting to look at there. And I didn't know how much of that could have been pattern and still some over recruited muscles versus structure at that point.
Right. Did you check the releve by any chance, or no?
We're getting there.
Okay, perfect.
I wanted to see what was happening at the hip first before
for sure.
My intuition was telling me that this is a problem from above TL and up. That may be the big, underlying driver here, but I wanted to be sure that I am not putting her in positions that her structure couldn't handle, and I just wanted to see what she looked like out of weight bearing.
For sure.
So that's why we did that. So then the next thing was to get her into what I consider kind of the, so we looked at all of that, and she does have a lot of movement at her TL. You could sit her on the, we sat up on the bed and crossed the arms and had them move and moved very well there. That wasn't the issue. The issue was above that. And the interesting thing that I saw with the rotation and sitting is that not a lot of head movement, not a lot of eye movements, even with cueing. Like, look back here at me, and the chin would kind of come around, but the eyes never really would. I'm like scratching my head here. Nobody can see it on the podcast, but my fingers up on my head going, why is she not using her eyes? Because usually I cue them and boom, right away it all comes in.
Yeah, but she's a dancer too.
How in the world is she turning?
I was going to say, how exactly? She's supposed to turn her head when she's on the dance.
Right. You have to spot. And that means that you got to have that whip.
Yeah.
So I said right away, okay, I've got you in the seated position. Let's do a quick slump test. So we did that. It was negative. All of her neuro stuff was negative. No sensory loss. All of her, reflexes and all of that stuff was all intact. She was actually quite strong over her foot. I just did a quick test, on the muscles in her foot, and inversion and eversion. There wasn't really a lot of difference side to side.
Right.
And neither one of them caused pain.
Interesting.
Tendonitis, really?
Yeah, exactly.
So,
So did she have problems walking at this point out of the boot, or was she okay?
Just complained about it being super stiff.
Got it. Okay. Got it. Okay.
So, and she didn't really ever have problems walking before. It was that releve.
Yes.
And then it turned into the landing. Centric landing. Yeah. The loading. She was losing her ability to load, probably because things were overworking so much.
Yep.
I just kind of went through and just checked her feet, to see if she had any abnormal stiffness anywhere. There may have been some stiffness in the midfoot, but again, at this point, it's hard to say. She was also in a boot for 2 weeks, so some of it could be over recruiting, some of it could just be stiff because she hasn't moved it. That's easy stuff to get going.
Right.
You can give them exercises and get them moving. My thought was, I got to get this kid back to bar.
Totally.
So that was going to be where we were going to go. I wanted to evaluate what she was doing and see what was happening. So I went to, instead of just doing more stuff in the middle of the room, I got the bar and said, let's go,
Yeah.
first position, second position, let's get into these positions. Let's start moving. I want to just see you do things. You tell me if you're having any pain, but we're just going to kind of go through it. And
Mm-hmm.
so we did. And the very first thing right out of the bat, right off the bat, the very first thing that I saw was when she did her, I can't even think of the name of it right now. Shoot. When you are in first position and then you do, all your stuff, and then you bend over at the hips and go down to the ground and come up.
Oh, yes.
I can't think of the name of it.
I forgot
Oh,
the
I hate
name
it
of it
when I
too.
do that. But anyway, as she went into full flexion in first position,
Yep.
you should see that at the hips and not at the back.
Correct.
Her thorax was super stiff. So there was an arching of her back as she went down, but that wasn't really what concerned me. What concerned me was when she got into that position, I said to her, because I saw her shift to the left, I said to her, I said, what's happening? I stopped her right there and I said, what's happening? And I said, can you come back over to the right? And she said, I can, but it hurts. So here comes my friend, the neural tension monster again.
Right, right.
And it took getting her into that extreme range of motion to pull it out, because she's so super flexible everywhere.
So she went into a full deep squat in first position?
Not squat. No. Yeah.
First position.
Where your knees and everything is straight and you bend straight over.
Of course, that tensions the nerve. Of course, got it.
Yeah.
Of course, neural tension. Of course.
Yeah,
Of course.
yeah, but it took that. It took that.
Yes, because
yeah.
So if you just did a standing
145 or 160 degree bend at the hip to get that
correct.
to come on. Yeah.
So even in a standing forward bend, you couldn't have even brought that on, and a slump obviously didn't bring it on. That makes complete sense. Yeah. Because with these, I think we mentioned this in another podcast as well. With these really super flexible girls, you need to wind them up a little bit.
Exactly.
Really, I mean, you really need to do that and to really find out if it is neural tension, and they're super flexible. So that's great stuff.
Yep.
So what happened then?
So that was good because it was a little eye-opening. I said, come out of that position a little bit and tell me when you can get back onto your right foot. So she did. She had to come up about maybe a third of the way, so she couldn't do the full all the way over and down.
Yeah.
So she came up about 1/3 of the way and she was able to do it. So that was first thing. When you go to class and you do this maneuver, you don't go all the way. You stay where, I don't want you to push through things, but I don't want you to have symptoms.
Yeah.
Right? Because if we respect that, it's going to get better. So I actually had her do it 2 or 3 times at one, lacking that last 1/3 of the range. And by the time we got to about the 4th one, she could go easier without it hurting.
Sure.
So she got to buy in right away. It's like that you back off of this. You need to make, here's what you feel how you're going that way. Oh, yeah. She just needed to learn that she was kind of making some of these compensations due to, so she could have been having symptoms in other things. She just was so good at, she's young, she's flexible, she's so good at just moving away from it that it didn't bother her.
I know, it's so funny.
It wasn't until she couldn't get away from something that it began to really bother her, right?
I know, and it's so funny because the boot, if it is indeed neural tension or whatever, a boot's going to make that worse because nerves are bloodsuckers; they need movement.
Right.
So I think what gets lost sometimes is people. I think we talked about this as well. We need to sort of, especially when you're a performing artist, a dancer, an athlete, or even just a normal population, I encourage them, and I know you do, to work out or to work out with their trainers or to do and you have to modify it because it's not only is it good for the nervous system, mentally, I think it really empowers the patient to know that they actually can do something even though they may have an injury. And a lot of people just say, oh, I'm not going to do anything. And I think that's a mistake. I really do.
Right. Absolutely. And I think telling young dancers, unless there's something seriously wrong, like a fracture, telling young dancers to not do anything is really, it said, no, we need to modify so that you can move in all the other ways that you're fine with. They took her away from, she could have been doing bar all this time, and with some modifications, it probably would have maybe even healed this up.
Yeah.
I don't know.
Yep.
All I
Yeah.
can say is what I saw when I had her, but I
Yep.
do know that I wouldn't have put her in a boot myself, but
No.
that's just the way
No.
it is, because I
Yep.
agree with you, especially if you can find, to me, nerves are involved anyway all the time, even if it
Yeah.
was
Yeah.
tendonitis, even
I
if it was an overuse, even if it was a whatever. I still think movement, maybe, some protection, but movement is the key,
Yeah,
definitely.
tendonitis is such an easy diagnosis to give to a dancer. I mean,
Yeah.
come on, let's
Oh,
get
that's
real
right.
here.
It's like, oh, you have tendonitis.
Right.
So they all run
Exactly.
around going, I have tendonitis, I have stiffness, I have tight psoases, I have,
Yep.
blah, blah, blah. Yeah, exactly. So anyway, once we found that, we were able to kind of start to change that. And then we took a look at, I had her do some protective releves with her feet forward in parallel, because I wanted to see what that looked like first. So I had her face the bar, put her hands on the bar, and just come up. And she still had a little bit of that weight shift to the left. That doesn't, still didn't concern me. I knew that was going to be there. We just played with it a little bit. What happens if
Mhm.
you go to the right? Well, it hurts a little bit. Okay, come down, go up halfway, give it a try. So we kind of started modifying her releve right away, so she could start bringing in her muscles and working, but not in a way that was going to, kind of increase the pain barometer there. And so then we moved it to, and I said, I want you to get the feel of where your feet are, like where your toes are, big toes
Mhm.
are on the ground. And when you move to first position, let's do this again. We're just going to go up into just that partial releve. Tell me how you're feeling.
Mhm.
And I said, and she said, I really feel like I was standing on my left leg a lot. I said, that's okay, because now you're aware of it. So just kind of even it out a little bit. She was able to go up about the same, as she was with her feet in parallel, but she really wanted to hang on the lateral side of her right foot. She really didn't want to
Mm.
bring her right toe down to the ground. So we needed to do some work there.
Yeah.
That whole area maybe have been, kind of ticked off with a little pain, because she was putting an abnormal twist in her foot as she was loading it.
Mhm.
She's
Yeah.
loading towards the outside of her foot rather than over the forefoot and over the big toe. So that's going to make going up on the point extremely difficult, because she wasn't able to use
Yeah.
her muscles,
To get the peroneals fired up. Yeah.
deep toe flexion and some of her other musculature to be able to pull her up onto point.
Mhm.
And how much of that was driven by the hip, I don't know. I don't think so. We pulled her turnout in just a little bit also to respect that right hip till we could get everything to kind of feel better.
Mhm.
I forgot to mention that earlier. So we were kind of working through that, and I said, okay, so now this is good. So that she had her routine for bar. She could
Mhm.
fully do her plies. That didn't seem to bother her. It was the
Mhm.
loading with, going upright that bothered her. So as long as she was not shifting off to the left, and she kind of, it gave her some things to focus on and work on. And I
Yeah.
told her, I said, I'm emailing your teacher. As we're talking,
Mhm.
I'm emailing, the correction, the things, not corrections, but modifications. I
Yep.
said, so your teacher's aware.
Yep.
That way everybody's playing on the same page. So anyway, I said, let's get to center floor. I want to see a few things. I know you haven't done it in a while, but I want to see you do some turns, because I'm still looking at this head and this chin
Mhm.
thing going on, and this stiff thorax. And it was amazing. I had her turn to the left. She did a little bit better with left turns. Then I had her turn, do some PK turns, which is where you're going, you actually put the foot into releve, so half releve, and you plant the releve and turn around it. So, and
Mhm.
the other foot comes up to the knee. They're the basic simple turns for ballet. And so I just had her do a few of those because I wanted to see what happened. And she said, it does, I can feel it a little bit. And I said, I know we're going to kind of stress this just a little bit, but I want to see what happens when you get going. So see if you can just go across the floor for me, because I
Mhm.
wasn't even looking at her foot at that point. I wanted to see what was happening up above. And the more she turned, the more her head went forward.
Oh, interesting.
And her trunk was, her thorax was completely lifted up, and that head was forward. And, she was just, you could tell she was working so hard to get around. And it was like,
Huh.
she doesn't have the, something's gone off in the vestibular system here.
Yeah, because
She doesn't have the ability to use her head to bring her system around, and that's a deep neurological system.
yeah, yeah,
And
for
it's like,
sure.
whatever reason, she's got that blocked, or maybe it never got developed. I don't know. I mean, and some people, they just, depends on. I was just so surprised when I saw it, because that's something I see much more typical in a postpartum patient than I see in a young 15-year-old dancer.
Yeah, I know. Well, dancer and a young 15-year-old who's not a dancer,
Right.
not uncommon, right? Because they're at their phones all the time. They're,
Right.
but dancers usually have like the quote unquote, nice line up and things like that. And I think
and have learned to use their eyes in their head to bring them around.
Totally. And I think, you could is the hip, the fact that it was 30% less, external rotation, could she compensate at the foot? Maybe.
But this was huge.
Yes.
Because this was keeping her entire system off kilter.
Correct.
And it's one of those kinds of really complex things. I was talking to the PT who is the PT for the 76ers, Scott Epsley.
Oh, nice.
Really, really smart guy, just very gracious. I went to a learning about rehabilitative ultrasound.
Oh, that's right. Yeah.
But anyway, he was talking about a couple of his ball players that have these chronic ankle sprains. And he goes, I'll tell you, it's just classic. He goes, when you slow the tape down and you watch them as they begin to roll their ankle, he goes, it's generally, like he said, if it was the right ankle, it's generally because they're either looking or throwing or doing something up and to the left quadrant.
Interesting.
And he said they've lost that neurological connection. They can't, he said, so he's learned to, with a lot of those high level athletes, to really pull that spinning and head turning and all of that upper body movement into everything that they're doing, not just, side to side in the clock, but, really having to turn and
That's
lift
great.
and, do all of this.
Yep.
So, but it was interesting, because I was looking at her and, I was thinking we need to do some upper mobility and disassociation of movement, of this whole upper quarter here to get her to balance better over her feet. So that was enough. I told her, I said, you've got your marching orders for bar. See you in a week. Call me if you have any problems.
Yep.
Email me right away if something that I asked you to do at bar, it just isn't working, whatever, but just go. And I thought, we're going to do this the next time she comes in because it was like too much at that point. I could have spent the whole day with her and
I know, right?
Overwhelmed her system. So the next time she came in, I really dove into, and she was doing better. She liked being at bar. She was delighted to be back at class and be with her friends, and things were going really well. And when can I start center floor? It's like, well, first we have to get you to full releve and some balance stuff before we get to center floor. But we'll get there, maybe next time. So let's work on that stuff to get you ready for center floor. So I basically, did some, just took a look at movement wise and mobilization, mobility wise of her upper trunk and her neck. And she had the AO region, very, very stiff in there. And again, for a 15-year-old, I'm kind of like, oh, what is this happening?
Yeah.
So I finally asked her mother, I said, can you give me a little history here? It's something that you may not have thought is important. Has she had any falls?
Yes.
Any kinds of accidents? Anything that...
Concussion?
Anything. Yeah, that, you just aren't thinking about with this. And sure enough... She had fallen out of a tree onto her head when she was young. Yep. And she was in a car accident.
Oh, there you go.
Of course, non-symptomatic.
Yep.
And so she's had a couple of those things. And so I'm thinking, okay, well, that may be where, I don't know, her mother could have told me she never had anything, but that doesn't mean they don't whack their head on something or, for whatever reason. But, it was just, it wasn't a red flag, but it was enough that it was like, for some reason, she's developed some, patterning and some overprotection around this area. And so then I also, because I usually always ask medical history, and they said there was nothing medical, in her history. And I said, does she have any breathing problems? And she said, well, she has allergies. And it's like, okay. 'Cause I'm thinking, well, why is, maybe there's something else driving the stiffness? Does she have a history of asthma, whatever it is? Seasonal allergies. And I said, okay, that topped on other things. I said, the reason I'm at, because the mom was interested and she was interested. And I said, because you're just kind of holding yourself, in this kind of position here a lot. And I want to figure out, where is this coming from? And can we get you out of it? Because I feel like if we can get this moving better, you're going to be doing better. So I actually decided that I was going to do some hands-on work. And I did some, just general myofascial mobilization system kind of approach, just as she was breathing, accentuating the exhale, giving her some spring for inhale, kind of just working on that, getting her
Yeah.
to vocalize a little bit, get into some lower pitches, open the throat a little bit, get some of that going, because I was going to use a little vocalization with her when I had her up on her feet.
Yep.
And then, we sat up and we did some stuff. We did some eye exercises and some head exercises, and I just had her basically hold her head still and turn her eyes side to side, as
Awesome.
quick as she could, and up and down. And then I had her hold her eyes still and turn her head, and, just to break it up a little bit, give her permission to kind of start to find some new patterns.
That's great. It reminds me of the junior golfer on our podcast. I think one of the early ones. Same thing. Got hit in the head with the golf ball. He was on his right leg. So these kids who have these issues, they're they're young. There's growing brains and heads, and when you see something like that, like you said, it's just not making sense. It doesn't make sense.
Right.
And people are like, "Oh, a fall is a fall. If you hit your head or you don't hit your head."
We're learning more and more about that, right? So
exactly.
We know better, we should do better.
Exactly.
So I just, started kind of working on things like that, and then I kind of combined it into, while she was sitting there on the bed, with her arms crossed again. It's like turn and look, and just really kind of began to cue it and give her some targets, and let's turn and look this way, let's turn and look that way, turn as fast as you can and look, just made it kind of some fun things and stuff like that. I said, now let's go out and do some turns. Let's go see, and so she actually started, I started cueing her. I said, tell me about, I don't think anybody ever, she understood what spotting was. And I said, do you think you're doing it? She goes, I have no idea. That kind of sheepish 15-year-old, maybe. Yeah. And it was like, let's really learn what spotting is.
Yep.
And so I taught her, and we did it slow. Here's your point. Turn your whole body around and come back and find that point. And I just had her walk around in circles until she could, start targeting with her eyes. And I said, now, make a half turn, find your target in the back, half turn, find your target in the front. You know where you're going. Your eyes should lead the way. Find the target turn, so she started to bring her head into the movement. And I said, now let's start doing some turns, to start to help her build that into her system, because it never made any sense to her, because she couldn't really use her head and neck that way, or she wasn't doing it that way. That pattern got set into her, and she was doing the best she could. She was compensating just fine. Who would have ever thought, right?
Right. So for the people who don't know, what is spotting?
Oh yeah, spotting. So spotting is a technique that dancers use when they're having to do multiple turns in rapid succession so that they don't get dizzy. And it's a technique of allowing your eyes to move really fast and find a target. And with that, your head is going to go with it, because your head is naturally going to go in the direction that your eyes are going. Yep. You can't spot with your head. You have to spot with your eyes.
Yep. Wow.
So very, very different, though, than what you will see with figure skaters, because they don't use spotting. They spin so fast that it's impossible to spot. And it's a different kind of back and forth, like almost, I don't even know what to call it, but it's a wobbling of the eyes. Somebody who treats figure skaters could probably explain it a lot better than me. I've never had the opportunity to treat a figure skater. But there's a whole different kind of mechanism that goes on so that their eyes are kind of working in a side-to-side fashion, in a certain direction while they're doing these like crazy spins. But for dance, spotting is crucial and critical, especially as you are beginning to develop this pattern and put it in. And somehow through the thing, she never got a chance to develop that naturally. Some kids just start turning, they naturally spot. I mean, it's just, most of them do. Some have to be taught. We have people at different neurological levels and different systems and things like that. So this was the deal here with her, was that she didn't have the ability to rapidly turn her eyes and head. And so that's why she was working so hard, particularly to the right more than the left, to get herself around. And over time, she couldn't do it. And as she worked harder and harder, her head went more forward, and of course, then you're kind of into that funky breathing where it's not great position for lovely deep inhales. So she starts panting. She's out of breath. And that makes you work harder.
I was just going to say, her whole body.
Yeah, it's kind of pulling her into a bit of a, almost, if you will, not not full blown, but a teeny bit of like an anxiety response to get herself around.
Yeah. Yeah.
And we all know where anxiety falls in the patterns when you have pain too. It's like
Yeah.
they start to feed on each other.
Uh-huh.
So, that was, so we spent the next, I got her back into center floor. She started working on balance stuff. She could work on, side to side and some different things. We weren't doing leaps and jumps yet, and she was still working on spins only with me,
Mm-hmm.
And so we did that for a couple of more weeks until she was able to get up onto point. That was the last thing we did. We had her into full releve flat, and she was
Mm-hmm.
coping quite well with it. Her turning was getting better.
Mm-hmm.
And so the final thing that we did was, we got her up onto point, and then we kind of played around. She finally was moving enough that I could actually kind of come in with her trunk and help her understand that, when you lift your trunk up, where everything goes backwards, that's why you're pulling your head forward.
Mm-hmm.
So
Mm-hmm.
I said it's just a natural thing, and I said, and
Yeah.
it's just something that you've been doing for a while, so you got really good at it.
Yeah.
So now you
Yeah.
just need to practice this and get better at this, and the
Yeah.
combination of the two is going to be where you'll find the middle that works for you.
Yeah.
And so, she was smart enough to get that, but for some reason I just didn't want to get into that trunk until I got that head eye and
Mm-hmm.
all of that balance stuff so much better for her.
Yeah.
And then it was easy to help her kind of feel, now where are you on your feet? Now what do you do?
Right.
And she could feel the shifting of the stuff, and she could understand that if she lifted her trunk up, how it threw her body backwards, and that,
Mm.
she would pull forward with her head,
Yeah, because
and yeah.
I'm just going to say, because you're giving her a better proprioceptive capabilities, and the head, they have the mechanoreceptors up in the neck and the head, and it's your vestibular, your balance center.
Mhm.
And I've have personally a lot of neck issues, and for me, when you were saying to whip the head around, I think I would be nauseous doing that,
Yeah.
and I think that it's the center, that the head and the neck are so important for everything,
Mhm.
especially when you turn, because you
Yeah.
have to turn your whole trunk, and
Right,
especially
and
for cancer.
we're designed to be
Yeah,
participatory,
yeah,
so we have to do it. And for a really good neurological response. So now, if she was dizzy or nauseous, and I'm so glad you brought that up, because if we had started doing some eye work and nausea had come in, that to me would have started to be a red flag. And I would
yeah,
have said, at this age, at 15, we
yes,
got to get we need you to, we just need to be sure we can push through this.
correct. Yeah,
That it's
exactly.
not, that this isn't something that we need to be worried about. Let's go get that, let's get you over to a good ENT, or
Yeah, yeah,
somebody, whoever
yeah,
the concussion person was, or whoever, I would use. But there's a number of people, just to make sure that there isn't something else organically going on that needed to be
yeah.
checked out. But no, she responded very well and very fast, and could
And
move through. But it's important to think about that, because
yeah,
if it had brought that on and there wasn't anything organic, I would need to scale that back quite a bit,
yep, yep,
because nausea is a symptom,
yep,
dizziness is
yep.
a symptom, and we don't
Symptom.
want them to have that. Yeah.
Yeah. Yeah, and in her, someone so young, you wouldn't, anticipate that. But
Right.
do you think that the position of her head was causing her, I'm putting my hands in quotes here, almost like to destabilize her right foot or her right
So
side?
I think her balance system, I think the position of her head and her thorax
Yep.
were her means of trying to find stability,
Mm-hmm.
and something she had relied on for a long time.
Yep.
And she was able to kind of muscle her way through until she couldn't.
Yep.
And because she couldn't get the fast response, because of that stiffness up there, for
Yep.
whatever reason it's there,
Yep.
I don't think it's like a true joint stiffness, but I mean, the area
Yeah.
was just not moving well and not
Yeah.
moving responsively well. And so that was making her drive harder through her feet.
Feet. Yep.
Yeah, to do
I mean,
that. Hmm.
yeah, I mean, the feet are rotary joints, the neck and
Yeah,
trunk are rotary joints. If you
right,
can't rotate above, you're going to do
right.
it more below.
And if
Yeah.
if you think about it, when you talked about proprioception, up to 50% of the proprioceptors in the body are located in the suboccipital region.
Yeah, for
So it's
sure.
pretty important to be
Yeah.
able to have a head that's moving around on top of the neck.
Mm-hmm.
And if it's only in one position all the time, then the rest of the system is only getting that input, and it's building a pattern around that input, because
Mm-hmm.
it's never getting another input to change. So I needed to give her some input so that she could begin to feel and start to change it a little bit.
Yep.
And as she did, I mean, again, she was very neuroplastic, and she did really well. And, she moved along and, was back and happy, and I haven't seen her in a while. And, the last time I talked to anybody that knows her, everything's fine. She's doing very well. I mean, her parents have been grateful, like, oh, this has been, such a good experience that for her
For
to
sure.
really learn how to take care of herself. And, and for us, to maybe question the healthcare providers around ballet a little bit more. And
Yeah, hello.
is there something else we could do? Yeah, I know it was good for everybody. They
Because you
were
didn't really
all
touch
very
her foot.
generous. Yeah.
Yeah. I mean, you didn't focus on the foot, and I
Right.
think with
But
especially
we
oh, go ahead.
focused on it enough so that she, yeah.
Yes.
Yeah.
You integrated it
But
into
we
full
didn't make it all
body.
about the foot. Well, your foot is stronger, so I don't know
Correct.
why you can't turn. No.
Yeah,
It's
no,
gotta
I mean,
look
you
at
didn't do any manual or,
right.
sweeping or
Right.
foot control exercises.
Mm-hmm.
Because if you started giving her foot control, like backwards walking, heel, toe, heel,
And a
split
15-year-old is
squats,
going to do it.
totally, and she's still going to do it with the forward head, and that's
Yeah.
that's just going to reinforce a poor motor
Mm-hmm.
pattern, and it would probably make her worse.
Yeah.
And I think that the beauty of this is that you're looking, especially with dancers, and it's very easy to hone in on the foot.
Yeah.
It really is. And,
Mm-hmm.
sometimes it is the foot. But with somebody like that, and with all dancers, you need to look at how they move. Don't just get them on the table, start mobilizing soft tissue with the foot. Because ultimately, she was in a boot. You're looking at the almost 2-3 months. It's not the foot. It's how she's moving. And I think this really shows the beauty of really, really looking up and down the whole chain and focusing on her background, hone in on the trauma and the fall. And I always tell people in my evaluations, I'm like, any falls are like, oh, nothing that matters. I said it all matters. You need to tell me. I'll be the judge whether it's relevant. And I say it nicely, but it's a lot of this stuff doesn't matter. I think this is great.
Yep. So anyway, so it was very, very interesting. Very interesting.
That's awesome.
With her, very interesting to see the changes she could make.
She must be so grateful.
So, but like I said, it all boils down to, the way that I progressed this was first I needed to get her hopeful and joy back into her life.
Yeah.
That's why we went right back to bar. And I didn't mess with any of the head stuff the first day. It was like, too much. She wanted to be in class. She wanted to know what she could do. And she wanted to know she was going to get better.
Yep.
So hit that first, then the next time it was like, now let's start taking a look at some other things, and let's start combining it. And how far can you go over, and what are your releves looking like now? How does it feel? Are you gripping the bar? Can you do it without holding on? We progressed all of those little things too as we went through because they were important.
Yeah.
She needed to kind of feel and bring herself into position over her feet. But then when she started getting into more movement patterns, leaping and turning, we really needed to bring that whole vestibular system back into play and help. And I used that to help drive the mobility in her thorax and her neck, because that system was going to drive it a lot better than me mobilizing her upper cervical spine. Or like I said, I did some breath work with her just so she could understand what a good inhale felt like, because, her trunk had been held so stiff for so long. But I really used the other system to help drive the mobility there. And it just seemed to be the way to go to pull the package together the best way for her.
So it's you mostly focused on working on, after the first visit, getting her at bar, mostly head, neck movements with eyes, the breathing, getting her up into the functional position, and working on her strategy for releve and for turning.
Yeah,
right?
exactly.
Okay.
And even things like if she was doing developpe with her arm and the gesture arm, it was like, are you following with your eyes?
Your eyes, right.
Follow.
Right.
I want you to over-exaggerate that. I told her, I said, I want you to come to like a drama queen.
Yeah, I know. It's funny.
And I said, you don't have to do that in class, but when you're practicing, you're playing around, I want you to do, do all those dramatic gestures and turn your head and roll your eyes and do that stuff, just kind of like, come on.
Yeah.
Maybe she wasn't that demonstrative in her communication cycle, but I said, I encouraged her. I said, do it with your parents, be just like really dramatic about everything, get them to laugh.
Right.
But I said, it'll just help kind of get all of this going a little bit better.
Yeah, that's awesome. Have you seen any of the work done with vision and eyes with glasses, like these well, I forgot what
Prism
that's called.
glasses.
Prism glasses. What do you
Yeah.
think about that?
Well, it depends upon those depend upon the what actually has happened in the central nervous system.
Yeah.
So if you have a central nervous system, if you have a field cut because
Mm-hmm.
your optic nerve has lost blood, or you've had a brain bleed or an infarct or something there, and you have a true visual cut,
Mm-hmm.
that's there no matter if you turn your head whatever side and all of that. You
Mm-hmm.
always, you may have that left medial visual cut that's always there. Your brain will learn to look around it like we do a blind spot.
Yep.
Over time, your brain will learn to kind of treat it like a blind spot and try to remember that it has to go in and out there to look, just kind of like when we drive. When you're driving the left-hand side, your mirror only catches so much. There's that little bit of blind spot. We all know as drivers that we have to look, because sometimes we're surprised by what might be sitting in that little spot. So that's a true visual field cut. If you have one-sided neglect, that's a whole different kind of thing, because that's a whole temporal spatial kind of deal that goes on. It's more global. And what it is that side of the world just doesn't exist. It's not just the body, but oftentimes the world, because optically they're not seeing it as well. And so what happens, so a left-sided neglect, what they end up doing is, instead of turning in to find the left side, they turn further to the right.
Yeah.
Because somewhere over on the right side at a 90-degree head turn becomes their center.
Yeah.
That's the center of their universe over there. And so what the prism glasses do is it pulls that vision around to show the left side.
Right.
So it helps them come out of that left side over here at 90 degrees, to the right, and it makes them come more to midline and over to the left. So it helps pull them visually around. Yeah, so it does nothing for a field cut, but it can help with those neglect kind of things that go on. I hate that word neglect, but that,
I know,
that lack of whatever that has been created because of the neurological damage. So
yeah. Oh, cool. Interesting.
Yeah, so that's what those prism glasses are good for. That really good for that.
Yeah. Awesome. Well, this was a great case. Loved it.
Yeah, fantastic.
Happy ending. Yeah, great.
Happy ending. Good ending. Okay.
Perfect. Thank you, guys. We really appreciate listening to the podcast, and we appreciate all of your reviews on iTunes. And if you have not yet written a review for us, we would really appreciate it if you would. And we're going to be adding some goodies to our podcast. We're going to have some little freebies coming up, PDF downloads and things like that. So look for that, and we will talk to you soon.
Thank you, Erica.
Thank you,
Have
Susan.
a great day. Thank you, everybody.
Bye.
Bye.